presented. And I hand over to Russell White for the case to be presented today. Thank you.
All right, thank you, Robert. As Robert has mentioned, I'm currently in the US, but I'll be heading back to Kenya shortly after I wrap up a few affairs and get back with the team. But I'm very happy to have our team here represented. Dr. Mwachiro heads up our endoscopy department. Dr. Mwachiro is a trained general surgeon and endoscopist. So at our hospital, the surgeons are heavy into the endoscopy, and I know that differs from site to site, but Mike is the director of our endoscopy unit, where we do a lot of advanced work in primarily esophageal cancer, but Mike does a lot in ERCP as well. And our case today will not be on esophageal cancer. We felt we had a very interesting case back in June and July, and we thought you might be interested in hearing about it. We actually tried a technique we had never used before, and I'll be interested to hear if some of you have used this technique, and if not, perhaps this might be eye-opening for you, and I hope something that you might be able to take away from this discussion as another tool in your arsenal to deal with problems. Dr. Agneta, as has been said, is one of our cardiothoracic fellows. She is finished general surgical training and pediatric surgical training, consultant in those two areas, and she's now undergoing what I tell her is her last training module, which is cardiothoracic surgery, and then she'll join me on faculty as a pediatric cardiac surgeon. We're very pleased to have Kulwinder from Milwaukee. Thank you for joining us as giving us endoscopic insight, and Dr. Matthew Reed from Australia from a general thoracic stroke foregut surgeon's point of view on this. So without further ado, I will ask Mike if he can bring his slides up, begin this discussion, share with you the case, and we will be doing this in segments where we'll be stopping intermittently and asking our panelists to give their input in a format of essentially, what would you do if you were in this situation? And I think this will open up some good questions for us all. And those of you in the audience may also have great questions for us. So Mike, why don't you take it away from there? Mike, you're muted.
Can you hear me now?
Yes.
Okay, let me start that again. Good morning, good afternoon, good evening, depending on where you are in the world. Welcome to the third Oeso webinar series. Today we will be sharing an interesting case that we managed here at TENWEC. And the title is Multidisciplinary Management of a Foreign Body in the Esophagus. The hosts, as you have been introduced to, is Prof. White, myself, and Dr. Agneta Odera, and Prof. Kulwinder and Dr. Matt Reed will be the panelists for this particular case. Let's see if it's okay. I just put up this slide to show the pilot centers of excellence in esophagology. And Bomet, Kenya is on the map there, the red dot in East Africa. Next slide. This slide just shows you where we are. So we are in East Africa, and you can see the little pullout of the Kenyan map. We are in the southwest area, around 3 hours drive from Nairobi. And this is the hospital. You can actually see an aerial view of the whole hospital. It serves 300 patients, 300 bed patients, serving a population of around 800,000. I put up the next slide just to show the upcoming cardiothoracic center, which will have both the cardiothoracic and endoscopic care being offered. And this will be completed in the next 2 to 3 years and will really help to enhance care in the region. as well as cement the position that we've been setting up as a pilot center of oesophagology. So I'll move on to the case presentation, and then Dr. Agneta Odera will continue from there. Let me just introduce the case. A 6-year-old female who was referred to Tenek Hospital from an outside facility. She complained of a persistent cough of at least 3 months duration, and she had been treated at several clinics empirically with different antibiotics for presumed pneumonia. She eventually had a chest radiograph performed, which revealed the presence of a foreign body in the esophagus, the level of the tracheal carina. Neither she nor her mother recalled the incident of ingesting the foreign body. The child stated that she was able to tolerate a normal diet without difficulty. She did not appear to be in any significant distress, but did have a persistent cough. She was in good nutritional status at that point and had no active respiratory infection. At this point, I'll let Dr. Agneta continue with the rest of the case.
So upon evaluation, other than a remarkable physical exam, she had chest radiographs which revealed a large foreign body. You can see that on the AP view and in the lateral view. And that just from the radiograph, it's not very easy to know whether it's located in the airway or in the esophagus. And then we elected to proceed to get a CT scan of her chest. And what we wanted to note is just look at the airway and the esophagus. And as we come towards the carina, you'll notice a foreign body that is lodged with significant impingement at the carina level, extending to the right main stem bronchus. And so you can begin to see the foreign body and significant surrounding edema and jutting into the right main stem. Based on those findings, we took a endoscopic assessment, and this confirmed the foreign body, which appeared to be a coin firmly wedged in the mid-esophagus. And we also noted a tracheoesophageal fistula present on the anterior surface of the esophagus. So at this point, I'd open up to the floor. What would you do?
So I would put this to Dr. Kulwinder, perhaps. Kulwinder Dua. So let us assume you are the endoscopist at this point, and you're looking at this endoscopic picture, and they did call me in to see this endoscopy. Showed a very eroded metal surface, which looked like a coin.
Yeah, can you hear me?
Esophageal fistula.
Yes.
Although there was no open passage, I might say. There was no air bubbling back, but it appeared that the coin extended through the anterior wall of the esophagus. So as an endoscopist, what would you consider at this point?
Yeah, thank you for including me in the panel. I would like to ask first, because we have a lot of endoscopic intervention capabilities which are scope dependent. So what endoscope was used in this child? A regular upper endoscope or a pediatric or that thin 5.3 millimeter diameter N30 Olympus, or what we sometimes call noodle scope? So if the scope that could be inserted in this kid was the regular upper endoscope, through which we have various accessories that we can pass, which we cannot pass with a noodle scope. So what endoscope was used? And could a therapeutic endoscope also be introduced in this kid?
We used a regular sized adult endoscope for this particular case. We could not be able to use the therapeutic endoscope because of accessibility issues. We only had access to the adult scope at this point in time.
So this,
Yes.
Mike, to clarify, had a single channel. This has a single channel for introducing therapeutic instruments.
That is correct, yes.
Yeah.
So Dr. Dua, with that information, what would you do if you were in our shoes seeing this child?
So knowing that a regular endoscope could be passed and not a therapeutic endoscope, So one option, that is endoscopic suturing devices, which generally require a 2-channel therapeutic scope, is out of the question. We will not be able to use any of the suturing options that we have. We can pass endoclips through a regular scope. And of course, we can pass devices that may be required to disimpact the coin based on how much it was embedded in the tissue. So based on the judgment of the endoscopist, if the coin was quite deeply embedded into fibrotic tissue, and if it was not possible to needle knife the tissue above the coin to sort of fillet open that area and take the coin out and then deal with the tracheoesophageal fistula, if that was not possible to disimpact the coin, then I think there are not many endoscopic options that can be done. Now we, not in the children population, but we have had in situations like this in the adults, sometimes put in an expandable stent, not necessarily to seal the tracheoesophageal fistula, but to also cause pressure necrosis of the tissue that is embedding the foreign body. And then when the stent is removed after 2 weeks, the tissue that has embedded the foreign body is kind of quite soft and necrotic, and sometimes we can peel out the foreign body. So these are certain endoscopic options I can think in this kid. Otherwise, I think the option would be to go to surgery.
Okay, yeah, the coin appeared extremely firmly lodged, and I did come into the endoscopy room myself with Dr. Mochiro, kind of palpated the coin with grasping forceps, and it was like the sword in the stone in King Arthur's story. And I was not King Arthur, did not feel that that would be able to come out. So I will turn this back over to Dr. Odera to share with us what happened next.
So based on the endoscopic description by Dr. White, we made no attempt to remove the foreign body endoscopically for fear of creating a larger tracheoesophageal fistula. So then we made the decision to proceed to surgery, prepared her blood work, got enough blood typed and crossed, and took her to the operating room. So at this point, what would be your operative strategy?
Yeah, and let's put this question to Matthew Reed and ask you from a foregut surgeon's point of view, what would be your strategy in this case as you're thinking about heading to the operating room?
Yeah, thanks, Russell. Firstly, just a couple of questions about the endoscopic sort of phase. How was the child anesthetized during that phase? Were they just sedated or were they intubated? What airway protection was there?
General anesthesia in the operating room.
And I guess was
With
endotracheal intubation.
Yeah. I guess from my point of view, if you deem that you couldn't do anything endoscopically at that time, was there a decision made about maybe doing a bronchoscopy to assess the airway as well at the same time? I mean, how convinced were you of this fistula, or even doing a contrast?
Yeah, go ahead, Dr. White.
Yeah, I would say we were very convinced in that. So there's a few things to take note of. One, in our setup in Kenya, you might wonder why this child never had a chest X-ray. This is very common for kids and adults even to go to outside small clinics where there are no X-ray facilities. And so, as was stated in the history, she'd been treated quite a few times for pneumonia and never gotten an X-ray. So this had been in there a long time. We're really not sure how long. The mother didn't know. At endoscopy, this is a large coin. This is the old-fashioned Kenya 1 shilling coin, which is nearly worthless now. But it's about a 24 millimeter coin, and only about half of the coin was visible in the esophageal lumen. So the other half was anteriorly and had to be in the trachea from our point of view. So for that reason, we did not bronchoscope her. We could have at that point in time, but I felt it was a pretty foregone conclusion that a tracheoesophageal fistula existed.
Yeah, well, yeah, that's I guess helpful extra information. I guess before proceeding to surgery, I guess there's a couple of things I guess to consider. The first one is, I guess, how sick the patient is, and you made the comment that they're relatively well, and there's from a nutritional aspect, there's no major issues. So I guess from that point of view, it gives you a bit more time. There's no, I guess, immediate urgency to do anything. You've got time to sort of plan, I guess, what you're going to do at surgery. And I guess before you operate, I guess you've got to anticipate what you're going to expect when you get in there to know how you're going to deal with the problem. So I would expect, you're going to have as you described, this large foreign body that's going to be difficult to remove, and a chronic some sort of chronic sepsis and a large fistula tract. So, you're thinking how you're going to deal with that, and if there's tissue loss, how you're going to manage that. And I always like using vascularized pedicles, so I'll have that in mind. But I guess my operative approach would be a standard right-sided posterolateral thoracotomy, and go in and assess things. And I guess the other thing is, depending on what treatment we end up doing for the fistula, you've also got to think of whether the child needs to be defunctioned from a GI point of view, depending on how, I guess, severe the injury is. And you've also got to think about long-term feeding options. So that would be my considerations before operating.
During endoscopy, could the scope pass this area and get to the stomach?
Mike, do you want to comment on that?
Yeah, so no attempt was made to pass the scope because of the coin was already lodged into the trachea. And this was a small child using a large normal adult scope at the procedure. So, yeah.
No, I was just interested that the child had no dysphagia, which is interesting.
Mm-hmm. Yeah, and it's a common finding that because of the way the coin is lodged, they are able to feed, and that's why they go for so long without presenting to the hospitals. And they're just treated for this sort of pneumonia-like symptoms at different places.
Yeah, so as all of you are aware, if this had been something like a watch type battery, that would have changed things dramatically, because they tend to cause a lot more damage due to electrical discharge of the battery and tend to burn through tissue. But this being what we assumed at the time was a coin, I think that explains her lack of dysphagia. It was remarkable how well she looked, and looking at the x-ray in her, there seemed to be a bit of a difference between those two. So let's move on to the next slide then. We did decide to go to the operating room, prepared her, as Dr. Odera said. One of my main concerns going in was how we would repair this. I assumed we would have a fairly large defect when we were able to remove this. And your options for repair, certainly direct repair is one, but I was concerned we wouldn't have enough good tissue to perform a direct repair. Segmental resection of the esophagus is, although some do it, and it can be done due to the fact that the submucosal plexus of arterioles is fairly extensive, so that as you're all well aware, the main blood supply to the thoracic esophagus comes from bronchial vessels and direct aortic small vessels. Segmental resection of the esophagus of any significant length at all is generally a bad idea, in my opinion, because you have tenuous tissue, you tend to get quite severe leaks, and this can certainly be life-threatening. So with that in mind, I felt we would need some sort of muscle flap to repair this. The options then would be an intercostal muscle flap, which is easy to harvest, generally quite reliable, but it's a small piece of tissue for a large defect. And I felt we would probably need more than that. You can use multiple intercostal flaps, but I wanted to be prepared for this. So we harvested the right latissimus dorsi muscle in a pedicle and prepared that ahead of time. And it's important, if one is going to consider using that muscle, that muscle be spared during the thoracotomy. In a standard right posterolateral thoracotomy, the latissimus dorsi muscle is usually transected and thus would be not available as a flap. So we prepared that ahead of time and then continued on with a standard posterolateral thoracotomy through the 5th intercostal space. We found a lot of adhesions between the lung, the middle and upper lobe of the lung, and the hilum of the lung, with its extensive fibrosis, essentially encompassing the entire region of the esophagus and the tracheal region of the carina, the carinal region of the trachea, extending more towards the right main stem. And it was really virtually impossible to create any dissection plane in this region. So we are essentially looking at a large mass, impossible to differentiate the plane at all between the trachea and the esophagus at that point, with a great deal of fibrosis overlying it. So again, for us to learn from this case, I would ask our expert, Dr. Reed, facing this, what I've tried to describe to you in word pictures. We did take photos, but photos are hard to see this very large fibrous mass. What would you do at that point surgically?
Surgically, in my institution, I'd be calling a friend at that stage, but I guess you're on your own in Tenwek. I've had the luxury of visiting you and seeing what resources you have, and it's amazing what you guys managed to do. But I guess in this situation, you sort of go back to basic principles, and as you describe, you describe this big sort of inflammatory mass. I would start the dissection away from that, try and find some normal esophagus. And I haven't had to operate in this sort of benign setting, but in a cancer, I try and get in that plane between the pericardium and the esophagus. At least if I could sling the esophagus and divide the azygos, hopefully at that level we'd be able to know where the esophagus was and maybe trace it into this mass and keep your dissection on the esophageal side. Hopefully you've got some indication where the airway is, and try and sort of also work on a broad front. I guess you don't want to dig any deep holes, sort of tiger country where you're operating. But that would be my approach. Try and start in some virginal sort of tissue if that's possible, and get some landmarks. I guess other things you could do would be potentially to pass the endoscope at the same time to get some sort of extra sort of indication of where the esophagus is lying. But that would be my techniques.
Thank you. Those are really good points. I think the idea of passing a scope might be helpful. You might even surgically be able to, as some would say, cut to the light, technique that's used in urologic surgery, where you're looking for the light if you're dealing with urethral strictures, and this would be something of that sort. We tried to identify, even the azygos vein was impossible to identify. And when we eventually later found it, it was nearly fully thrombosed because of this this difficulty. So let's go on to the next slide. What we eventually chose to do, I palpated with the other surgeons working with me, palpated the area, felt for the firmest part of this very scarred mass. And as Dr. Reed has said, I tried to err toward the esophagus, remaining posteriorly. In my thinking, my thought process in a case like this would be that if I destroy a great deal of the carina of the trachea, I'm in a very bad position trying to reconstruct that. If I end up destroying a significant amount of the esophagus, I do have a fallback procedure, which would be an esophagectomy and gastric replacement of that. So with that in mind, I just took a scalpel and cut down on the firmest part. And thankfully, we were in the right spot, and very quickly we came upon the edge of the coin, enlarged that incision superiorly and inferiorly, and were able to extract this coin. And at that point, we were looking into the esophageal orifice, the main carina, and the right main stem bronchus. Of course, this gave our anesthesiologist some anxiety, as there was loss of airway pressure, but we were able to control that pretty simply with a finger over the hole while we continued the dissection. So now, Dr. Reed, Matt, the coin is extracted, and we have what is essentially, again, in the middle of this fibrous mass. We're in the lumens, but we've got a lot of fibrous tissue around the entire area. How would you proceed then? The thought of simply closing that did not appeal to me well, and I'd be curious about your thoughts surgically at that point.
Well, I think the main thing is to find the defect as best you can. From what I understand, it sounds like you're looking from within the esophagus at the airway. Did you manage to separate a plane at all between the esophagus and the airway?
There was really, you're quite correct. I had to extend that incision posteriorly to finally define, and at that point, then I had two separate holes. So I'm looking at a hole in the esophagus and one hole into the posterior tracheal carina, right at the level of the right main stem takeoff.
Okay, so in that situation, then you've managed to separate the defects. You've got an esophageal defect and an airway defect, and then you have to work out how you're going to manage both of those individually. And from the airway side of things, I guess it all depends on what the quality of the tissue is like. I imagine it's pretty awful fibrotic tissue. I guess going by principles, you'd like to debride any necrotic tissue and get back to healthy tissue, and then you have to assess, I guess, what the tissue loss is and how much tissue you have to replace. The cases that I've been involved from a malignant point of view with these sort of fistulas, we've managed to patch with a collagen patch, but I know people also do pleural patches and pericardial patches. So I would be interested in putting a patch there for the airway and then putting a vascularized pedicle. Like you've already prepared your lat dorsi, I'd be swinging that over the top for the airway. And for the esophagus, once again, I'd be trying to debride it back to healthy edges. And then ideally, if you've got enough lumen left to try and close that, but I would be closing it over a T-tube and externalizing that, so you've got a controlled fistula. I guess that's how I'd manage those two defects. But prior to that, though, I guess you need to allow your anaesthetist, I guess, to safely ventilate the patient. And I assume that they would be putting a left bronchial tube down.
Okay, some very good thoughts, and you bring up the point that this is a benign situation process, and in fact, if this were a malignant process, I would be loath to take the patient to the operating room, and I would do all that I could to manage this endoscopically with certainly an esophageal stent and possibly a bronchial stent as well. In a palliative attempt to care for that patient. This again being a benign situation, we were not hesitant to cut into disease tissue. We felt fibrotic reaction and certainly not malignancy. Let's go on to the next slide then. What we found, we did just what you said, debrided the tissue. Thankfully, the fibrous tissue around the trachea was less dense, and we had to do minimal dissection there. and we're able to actually close that defect primarily with permanent interrupted sutures, still feeling that would need a flap to fully bring about healing. But we were able to close that primarily and continue with ventilation without having to pass a left-sided bronchial tube. We did find purulent material in the right main stem, which we suctioned out. We then passed a nasogastric tube, and I say under direct vision, that means it was passed through the nose and down the throat by the anesthesiologist, but I could visualize the tube passing through the esophageal defect and going distally into the stomach. So we debrided all the tissue that was non-viable, and what we ended up with was about a 6 centimeter long defect in the esophagus that involved about 50% of the circumference of the anterior wall of the esophagus. So a large defect. Any attempt, in my opinion, to close that primarily would certainly lead to a fairly devastating stenosis of the esophagus. So we did not attempt to close that primarily at all. We took our previously prepared latissimus dorsi flap, and I should note here that we passed it through a separate intercostal incision to achieve maximal length. So we made a separate incision on the, not in the skin, but through the chest wall at the third intercostal space, passed the muscle through and divided that flap into 2 tongues of muscle flap. So any of you who worked with the latissimus dorsi, it's a big, beefy, healthy muscle. And we had 2 very good sized flaps. One of those we sutured posteriorly to the tracheobronchial defect to buttress that repair. And the other tongue we used without any attempt at primary closure. We sutured it with interrupted sutures around the entire edge of the esophageal defect. Next slide, please. We irrigated out the chest thoroughly, left 2 chest tubes in place, gave intercostal nerve blocks for this child, and closed and took the patient to the intensive care unit. She was doing well. She was extubated in the operating room, and we started feeds via the nasogastric tube with the child sitting up at at least 45-degree angle during this time. And she was really doing quite well. But on post-op day 5, yes.
I guess at the completion of that thoracic phase, I would be considering, long-term feeding options and a venting gastrostomy. I guess this is going to take a long time to heal, and you're dealing with a young child. I guess having a nasal tube in there for extended periods is going to be difficult to manage. That would be the only other thing I would consider at that stage.
Agreed. We did discuss that option. We felt that, and if that were going to be done, of course, that would need to be through an open procedure. We did not feel it would be wise or safe to pass a endoscopically placed percutaneous tube. But we felt we would have a reasonable chance with feeding the stomach since this was mid-thoracic esophagus. So we continued to feed that way. On post-op day 5, though, we noted that the child had a low-grade tachycardia and increasing white blood cell count. So again, the question comes back to either of our panelists: what would you do now?
Yeah, I would be concerned about a leak, obviously. So I would go with water-soluble contrast study. It could be either just a simple water-soluble swallow fluoroscopy study, or one could do an oral contrast CT scan just to see the, if there is a leak, where is the leak extending up to? And once in a while, as a poor man's alternative option, we sometimes give the patient some colored material like methylene blue colored water to swallow and see if it is coming out in the chest tube. But I would go with a water soluble fluoroscopy or water oral swallow CT scan.
Yeah.
I guess
and
my preference would be for some cross-sectional imaging as well. I agree with the contrast to see if there's a leak, but I also want to know, I guess, if there's a mediastinal collection that needs draining as well.
No, excellent points.
Yeah, so that's where the oral contrast CT scan would have been, the option, but it's expensive.
Yeah, it's a good point, Kulwinder. Up until about, I think it was probably 10 years ago, maybe 8 to 10 years ago, was the first time we got a CT scanner at Tenwick Hospital. We do now have a very nice CT scanner, but prior to 10 years ago, when I was managing these patients, I've been at Tenwick for 23 years now, we would have not had that luxury to do that. We wouldn't have even had that for a diagnostic procedure. So we did elect to image the patient, and we can go on to the next slide, and I'll turn things over now to Dr. Odera to share what happened next.
So we performed a water-soluble contrast study using gastrography. This was given to her by mouth and a direct fluoroscopic examination. It revealed what appeared to be a contained leak in the region of the proximal extent of the muscle flap. So then to be able to delineate this defect well, we proceeded to place under general anesthesia, again with endotracheal intubation, and we were careful not to pass beyond the point of the tracheal repair with careful positive pressure ventilation. Then she had the adult GI endoscope introduced carefully. And at this point, we saw the muscle flap, which seemed nice and pink, well vascularized with no sign of ischemia or necrosis, but there was a small defect at the proximal extent of the esophageal repair. And so we'll just show you some endoscopic images. Okay. And you can see we're coming up to the other site of the defect. And there about to the left of the screen, you can begin to appreciate the muscle flap. Now it's at the 12 o'clock position. And as mentioned, the defect was about 6 centimeters in length. So you can appreciate the flap along that side.
I might just add, oh, go ahead, Agneta, you're showing the
and this is
fluoroscopy.
the fluoroscopy that was done before the endoscopy, and you can appreciate contrast going down. And there's a little bit of spillage of contrast externally into the right side. Yes, over back to Dr. White.
Well, I would just add, this is something, another perhaps learning point. Many people feel hesitant to endoscope patients who have had a recent procedure, an esophageal anastomosis or something of that nature. I'd be interested to get Kulwinder's thoughts, because I've become very liberal with endoscopy. We do a lot of esophagectomies for cancer, and any patient who I'm concerned about on post-op day 3 or 4 who has a mild tachycardia or a white count elevation or fever, our first line of therapy is generally endoscopy to look at the site. And I think it's a good point, particularly for younger surgeons, to keep that in your arsenal again, that a well-done endoscopy can show you a lot, and if it's done in appropriate fashion, your chance of creating a problem is quite minimal. And Kulinder, maybe you can comment on that particular point of endoscopic examination shortly after an esophageal anastomotic procedure.
Yeah, no, I think I totally agree with you. We always endoscope these patients. We are not worried about endoscopy making things worse. Um, Depending on even other areas of the GI tract, the only difference being that instead of room air, we use CO2 for insufflation and keep our insufflation to the minimum. The reason endoscopy is important is that it gives you endoscopically the lay of the land, if you may, so that you can decide endoscopic options. There are so many of them around, and without doing an endoscopy, you will not know what endoscopic option that can be applied and save the surgery for save the patient from going to surgery again. So yes, we do endoscopy in all of these patients without any concern.
All right, then,
The
so
same.
we've thank you, Matt. We've demonstrated this, this small leak proximally, and that would be the spot you would expect it. That's the hardest place to suture surgically. It's at the proximal end of your flap. It's as you're sewing down the flap. These sutures at the proximal extent, I would always put in left untied and put a number of them in, because once you tie down that first one, it's very hard to see to get the next ones placed. So I would put them all through the wall of the esophagus and through the muscle flap, but leave them loose until I have that whole proximal corner covered with sutures. But again, if a leak were going to happen, this would be the place I would expect it. So we've demonstrated the leak. We've seen it on endoscopy and with fluoroscopy. Let's hear from our panelists. Let's start with Dr. Kulinder Dua and ask how you would proceed, and Dr. Reed to follow.
So I see two options over here. Based on the weight of the kid, if we are going with the stent option, we have stents in the market that are 12 millimeter in diameter, 16 millimeter in diameter, 18 and above. They go up to 25 millimeter in diameter. So based on the kid's esophageal diameter and size and body weight, these are all fully covered stents, off-label use for benign indication. They are actually labeled used for cancer. But if the kid needs a 12 millimeter diameter stent, it's available. If the kid needs a stent which is even smaller than 12 millimeter in diameter, then I use fully covered bile duct stents, biliary metal stents. We have kids over here. Our center is a regional center for esophageal atresia, and when these kids have surgery, they have leaks or strictures post-surgery. We are using fully covered bile duct stents even in infants, and we are just about finishing writing up our case series. So if we go with the stent option, and the concern is the diameter of the stent, there are stents available that can be used. Question with the stent, however, is that without a stricture, they will migrate. So one of the techniques, we have two videos on that, which were accepted for video presentation in the last two DDWs on how to anchor the stent by tying a ligature. We partially open the stent, tie a ligature to the lower end of the stent, recapture the stent, and then deploy it in the patient. And that silk suture thread is then anchored to the patient's nostril, or in Korea, they anchor it to the ear lobe of the patient. So the stent is like suspended in place with a ligature attached to it. You can also have a ligature attached to a clip and then clip it on the top end of the stent and release it, and then anchor the ligature to the nostril to prevent it from migration. So that is one option. And the second option would be endoscopic vacuum therapy, provided there are no exclusion criteria for that in terms of a major vessel being anywhere around that area. The track is not going out into the skin. If there is a cutaneous fistula, then when you apply vacuum, the air from the skin gets sucked in and the vacuum doesn't work. So there are few exclusion criteria. So I would go with either of the two, the stent option or with the endoscopic vacuum therapy option. Now, one can also think about looking at the leak site. Now, it's a 6 centimeter segment, but most of it is covered by the muscle. In that 6 centimeter segment, if there's a tiny hole someplace that is the culprit of the leak, then you can even think of endoscopic clipping that site if you want to.
Okay, and Dr. Reed, your thoughts?
Sorry, I was on mute. I'd be going through a similar thought process. I guess I would be reluctant to use a stent though in the benign setting. I've only sort of either witnessed or heard of bad things happening with, you know, migration and erosion. We had a case at our hospital earlier this year with an aberrant subclavian vessel where a stent sort of eroded into. But I think, yeah, if you're convinced it's a contained collection, then yeah, endoscopic management would be appropriate. If the hole's big enough, you can use an endovac. If it's a small hole, sometimes the double pigtail drain is sufficient just to drain that cavity. But yeah, we've had a lot of, we use the endovac quite liberally here with a, you know, a leaked post-esophagectomy, as well as we do a lot of bariatric surgery, and, you know, with a sleeve leak, it's used quite a lot in that situation. So we've got a lot of experience with an endovac. And
so there's a question about what about Apollo endoscopic suturing device? That cannot be used in this kit because I was told that 2-channel therapeutic endoscope could not be or was not feasible to pass in this kit. And for endoscopic Apollo suturing device, we do need a 2-channel therapeutic scope.
And I would be reluctant to close a defect if you've got a collection on the other side. You need to drain that cavity, otherwise you've got ongoing sepsis. So either you have a drain that's placed externally alongside the defect, but that's why something like an endovac would be good. And even a covered stent would leave you with a collection that's not draining. So.
All right, let's go over to Mike Monchero to share with us what we did in this case.
Okay, so we decided to continue with management. So given the size of the child and the discussion we just had about the options for stent choice, we did not have a small diameter esophageal stent, and therefore we made a decision to proceed with utilization of intraluminal negative pressure device. Now we had to look up this, we didn't have any of the commercial available options at our institution. And so we looked up the literature on what has been done, who has used it, and how it has been constructed. And based on that, we then simply constructed in the operating room using a piece of gauze that we cut into the appropriate size. We attached it to the end of a nasogastric tube. We actually first passed the nasogastric tube through the nose into the mouth, pulled it out, and then attached the piece of gauze, and we added extra holes at the distal end. And then we also added a piece of suture to anchor the end of the device so that you can be able to pull it through. And then the gauze was placed directly into the cavity created by the esophageal disruption. This is a picture showing the assembly, and you can see it's simple available material. Before placing it in the patient, we used a silk braided suture for that. Next. And then you have an endoscopic picture. At the same sitting, we also did, and I let Dr. Agneta talk about that thoracoscopic procedure because of the collection that was in the chest.
Yeah, so we did a VATS procedure to help evacuate the purulent material that had collected from the leak into the chest side. And at this point, we left 2 chest tubes with one near the site of the leak. And then we performed a mini laparotomy to place a gastrojet tube. So the gastrostomy portion would be used to decompress the stomach, again, to prevent upward swelling and allow the leak site to heal. And the jejunal tube was placed distal to the ligament of Treves to allow the patient to have enteral nutritional support. And we began this phase on the second day post-surgery and maintained her on negative pressure suction via the endovac device. So on post-operative day 8, after 3 days of the continued negative low pressure, we took the child back to the operating room, removed the sponge and examined the site. We noticed that she began to have healthy granulation tissue with no signs of purulence. So at that point, we elected to replace the endovac sponge and decided to leave it for a longer duration. We were happy that it wasn't causing any problems with the airway and it was not near any vascular structures previously mentioned. We also had the child complete a 7-day course of extended antibiotic and antifungal coverage.
Okay, so now we'll show you an endoscopic picture. This was after removing the second, so this was the second endoscopy visit, and you can see this picture shows where the flap was. The defect was at the top, which you can see, and we were not convinced that the defect had completely closed. There wasn't enough granulation tissue. The place still raw and inflamed. And so based on this, we actually made a decision to put in a second, to replace the endovac and put a new one. We decided to actually change the choice of endovac. So instead of using the gauze, we now switched and used a piece of foam like what we use for wound vacs here. And so we made it in the same fashion. The only difference was that this time we switched it and used a piece of sponge. Next. This is actually the same, yes, and you can see to get appropriate position, we ended up using external markers and a fluoroscopy. These images show placement of 2 needles, one at the proximal site of the flap and the other one at the distal portion.
Yeah, so this is a technique that we think can be deployed if you're doing endoscopy in little children, because this problem of foreign body impaction can happen in children as small size as 1 year old. So using a pediatric scope and trying to pass the endovac sponge in, you have very limited space to be able to fit all those devices. So if you can use a capped hypodermic needle and via endoscopy be able to delineate the upper or proximal and distal extent of the lesion and the area you're trying to cover, then you can pass down. This is the NG with the sponge around it. You can pass that distally and then under fluoroscopic vision, pull it up and make sure that it covers the area as highlighted by the needles.
And one additional comment is to soak. We soaked the sponge in contrast to make it visible on fluoroscopy. That way, and this view you see, so the endoscope was in position above and the scope was also appropriately positioned across the 2 markers.
Yeah, this technique can also be used to appropriately place stents. If we had the biliary stent or a small esophageal stent, you can use it to appropriately position the stent to cover the area of the defect.
So in this setting, I take it the sponge is within the lumen of the esophagus and not through the defect?
Yes, that is correct. So the lumen size was not large enough for us to shove this entire thing in there. So we elected to sit it in the cavity, but not into the chest. So it was still able to suction both what was in the chest and what was in the esophageal lumen. Yeah.
I guess when we get to that stage with the track, you can even pass a tube in without a sponge on it and just have that in the cavity draining.
Mm-hmm. Okay, thank you.
Okay, so to proceed, we continued with feeds, and then 7 days later, we took her back an endoscopic assessment, retrieved the sponge, and noticed that there was satisfactory healing and good granulation tissue. We also performed an on-table leak test with water-soluble contrast, and this was negative. So then we started the child on oral diet with liquids and kept the PEG tube in place and continued to watch her with a very low threshold to reevaluate her. On postoperative day 20, so this is 5 days after initiating oral diet. We noticed that she was having tachycardia again and signs of sepsis with an elevated white count. At this point, how would you proceed?
Matt Reed, why don't you give us your thoughts?
Sorry, I just lost you. Can you go back one slide? I got the impression she was re-presenting with sepsis. Is that right?
That is correct.
Well, then I would start again and work her up. And I mean, you want to be doing some probably another contrast study to see if there's still a leak or a collection, and whether there's any collection within the thoracic cavity as well. So whether it's mediastinal or thoracic. So you want to know what you're dealing with, and I'd be keeping her on antibiotics, and I'd be doing a septic workup as well, blood cultures.
All right, Agneta, I think we probably need to move on with time here to leave some time at the end for comments from others.
Yes, so we did a repeat imaging and the leak tests were negative. And we suspected that she had a subclinical leak that had healed spontaneously. But she had a collection in her chest, so she had a subdiaphragmatic collection. So we took her for thoracotomy and washed that out and did a limited decortication, expanded her antibiotic spectrum to vancomycin and meropenem, and then she fully recovered from that surgery, and we were able to discharge her home after gradual improvement. She presented 6 weeks post placement and repeated the esophagoscopy and showed that the site had completely repaired. We were able to remove the PEG tube. She's currently well and has come for 2 clinic visits and has been gaining weight.
So did you say she had a subdiaphragmatic collection, or was it in the chest?
I'm sorry, it was a supradiaphragmatic.
Okay, thank you.
Then we're going to show you the last endoscopy video. So this was on her follow-up visit. And as you can see, we were assessing the healing of the area that had the defect. This scope just shows the esophageal mucosa. The flap area will be appearing at the, I think the orientation has just changed, 7 o'clock position and 5 o'clock position. The scope was turned a little bit around, and you can see there that it was actually now looking much better. It was healed out. There was no sign of inflammation or raw areas. So we were happy. We did a leak test at the same visit, and that looks negative.
So,
yeah, go ahead, Dr. Wright.
To bear in mind here, number one, we're in a relatively underserved, underprivileged area, and so we don't have many of the gadgets and tools that are available in some of the Western settings. And so the idea, this is the first time we'd ever used a negative pressure device in the esophagus, as Mike mentioned, but we felt this was a good candidate for this. And some might think you need to wait and order something from a supplier. As Mike has shown, we're able to do this with materials readily available in the operating room. Simply a radiopaque gauze sponge cut to a size, attached to a nasogastric tube, and it functioned very well in this case. It was a challenging case, and as shown, took 3 weeks to get the patient through all of this, but she's done very well through all of this. So from our perspective, some of the take-home points that are in the next slide, maybe you can move on to the next slide, that as in all esophageal surgery, clinical judgment and frequent observations are quite important. A patient on post-op day 3 who has a fever and a white count should not be assumed to be atelectasis or something else, but should be assumed to be a surgical problem that needs to be investigated, and timing is key. One needs to keep an eye on subtle changes in the clinical parameters of that patient. Foreign body impactions and fistula formation challenging to manage, especially in the pediatric population. This is one of the larger children. As Dr. Odero mentioned, we get these sometimes in very young children, and a multidisciplinary approach is key. In our situation, where we have the luxury that our endoscopists are surgeons as well, and we have a very close working relationship, so that we can involve each other very easily in these cases. I think planning ahead is important. Like in this case, choosing ahead of time to have a latissimus dorsi flap available. And then this option of an endovac therapy, and Kulinder has mentioned that they use them, and Matt Reed as well. For us, this was the first time. We were very pleased with that, with what we were able to do, and provide it through locally available material. So I think I would give our some of your final thoughts, and then we have some time for those who may want to ask questions from the audience. I would look, I think, to Frederick, if when our two panelists have spoken, maybe you can manage taking questions of those who would like to share them directly. So Kulinder, please share with us your final thoughts on this, and then Matt, and then we'll turn it to Frederick to take questions from the audience.
Oh. Well, first of all, my congratulations in successfully dealing with this challenging case in an environment with limited resources. I think all the steps highlight everything that you mentioned in the take-home messages. It has to be multidisciplinary, and the choice of therapy is based and even altered and changed as time goes by and as the clinical scenario involves. Very few head-to-head comparisons have been done with various endoscopic approaches to close leaks, fistulas, and so on. But endoscopic vacuum therapy is sort of, it started being used for esophageal leaks and perforations in 2008. So it's a new kid in the block, and the results are much greater than some of our other modalities. Limited options in a kid is another issue, where many of these alternatives we use in adults cannot be applied. There is only one study I saw in the pediatric population where endoscopic vacuum therapy was compared head-on with the esophageal stents, and the success rate of EVT was around 85%, 88% or so, and that of the stent was around 68%. The size and the diameter of the stents, as I mentioned, now they are available in the market if you need smaller sizes, but stents can cut both ways. If you land up with a complication, they can be devastating. So I think the right choice was made over here, and I'm glad it worked.
All right, and Matt, your thoughts on this?
Yeah, thanks, Russ. Yeah, as Kulinder said, congratulations. It was an extremely complex case, and I think you've achieved a great result there. I would echo sort of the same sentiments that you said, as well as Kulinder. I think the main thing in a complex case like this is to sort of plan ahead, and I think you did that really well. And you also need to have good, I guess, fallback options and things to get you out of trouble, and you've shown that here quite successfully. I like the endovac as an option in this setting. I think it's really good in helping to control sepsis, and when you have a cavity, to help that sort of granulate up. And yeah, we fashion them ourselves. I noticed there's been a couple of questions on the chat asking how you exactly make them and insert them. I guess one question I had was, how do you achieve your negative pressure? Because you can connect them to a pump, you can connect them to wall suction, but what I've found is you can even just hook them up to a ReadyVac bottle. that even achieves sort of 100 millimeters of mercury negative pressure. So you don't need anything fancy to achieve that. And I was just, maybe you could answer that, how you managed to achieve the negative pressure.
Olé a levé la main.
Yeah, we connected the patient directly to wall. There's not really a consensus view on how much negative pressure needs to be
Collé a levé la
applied.
main, hein.
And it's really quite different than other settings because you're in a lumen, you're intraluminally, as opposed to a wound vac on another part of the body where you're not getting air coming back. So you will get air from the GI tract, of course, as well. So we used regular wall suction on this patient. Matt, you might comment, I might ask you to comment on something you mentioned earlier, and that is a choice of placement of a vac, of the sponge itself. On the esophageal side of the leak, through the leak, put the sponge through the leak, or place the sponge essentially external to the esophagus through the leak into the cavity, and how you think about these things, and perhaps Kulwinder as well, your thoughts on that question.
And just after, we have Denis Collet who would like to intervene afterwards, and a question from Shilpa on the chat.
Yes, I have one comment and one question. My comment is about the option to place the sponge in the esophageal lumen, which is a very good option in my opinion. The device provided by on the market by B. Braun recommend to place the sponge in the defect and the cavity around the esophagus. I think it is very hard, and maybe it is not the best option. And the option to place the sponge in the lumen is, in my opinion, very, very good. My question is, with this experience, would you consider now that it would be interesting to place the sponge at the time of the operation? I mean, when you do a laparotomy and when you put a vacuum therapy at the end of some laparotomy for emergency, you place the vacuum therapy exactly at the time of the operation. It would be exactly the same for to treat the defect of the esophagus. And I think it might be interesting to place the vacuum therapy at the time of the esophageal repair.
I think that's a great point you bring up. And I think Mike Monturo and I even discussed that as we were managing this patient, because you're quite right. In frequent situations like in plastic surgery, if you create a large flap, either in a mastectomy type situation or anything where you have large flap area, it's quite common to apply negative pressure to that. And this was a large flap, a large area. And I think that's an excellent idea. And if we're faced with this again in the future, I think we would proceed in that way and place the end of vac at the time leaks. It's a good point that may prevent, obviously, if you have a huge defect and you technically not closed it, it's probably not going to save you, but it may save you from small leaks that would not have to become clinically significant.
Yeah, one of the concerns I have with that is that when we do this endoscopically, we go in every 5 to 6 days and change the sponge. The cavity shrinks, the size of if you're going to put the sponge into the cavity, after every 5 days, when we are changing the sponge, we are using a smaller size until the cavity sort of granulates and closes. So if you're going to place it surgically, I don't know whether every 5 days replacement is possible if the vacuum catheter is coming out through the skin as a drain, and how you can change it frequently as we do endoscopically.
Yeah, I think my thoughts on that would be that we would place it endoscopically in standard fashion in the operating room at the end of the case. And as you rightly mentioned, change that regularly. if one were placing it prophylactically in that situation, I'm not aware of any papers on that, but my thought would be I would probably go in after 5 days, as you've mentioned, and examine the site and do a leak test with contrast. And if that were all good, I might be done at that point, as opposed to this kind of a case where we're trying to deal with an already established leak. Frederick, let me turn to you and see if there are other questions that people want to ask.
We have a question on the chat from Dr. Sharma. Is there any risk of the gauze being displaced into the mediastinum or risk to the surrounding structures like aorta? And are there any specific locations where it can be applied safely?
Kulwinder, you may have the most experience with this. Would you try to answer that question for?
Yes, I think that dislodgement is not sort of something that cannot happen. It can happen, but it much depends on the way you anchor the sponge to the tip of the nasogastric tube. We also assemble our own. The only company I know that comes with a preformed packet is from Germany, which I'm not sure is available in the US, but we make our own. And when we pull the nasogastric tube out from the patient's mouth to attach the sponge, we wrap it with the silk sutures. And then one suture is through the sponge, through the tube. It is the needle pierces through the nasogastric tube, and therefore the sponge is anchored with the suture going from the sponge into the tube, coming out of the tube, and then tying it at the lower end, and the similar suture at the top end. And the rest of it is just wrapped around sutures. So it is anchored fairly securely, and that kind of almost eliminates the possibility of the sponge dislodging. It can erode actually into the wall. Sometimes the tube can cause bleeding, is known to be one of the serious complications that can happen just from the granulation tissue and the wall of the infected contained cavity, where there could be a vessel that could be eroded. But dislodgement, even if it happens, when we are going to exchange our tube and we find that the sponge dislodged, it's very easy to endoscopically go and catch it and pull it out.
Yeah. Do you mind if I make some comments, Russell?
Yes, please do, Matt.
I think you asked earlier, I think, where we place the sponge. Now, if there's a big defect and a big cavity, we place it through the defect into the cavity. And usually it takes 2 or 3 changes of the sponge. And, you know, as was mentioned, we put a smaller sponge in each time, and you see nice granulation tissue forming. If it gets to the point where the defect's just too small, then on occasions we've left a sponge in the lumen of the esophagus. Alternatively, you know, we have those double pigtail catheters that we can leave in and drain the cavity. But I've also, if you want, I've got a short, like 1 or 2 minute video. When I did my fellowship at the Alfred, one of the registrars put a nice instructional video together. So if you want, I can screen share and show that video if it will help the audience.
Frederick, do we have time to show that?
Yeah, we do. And then we have a comment from Eric and then Hiroshi.
Okay, so if you enable some sharing, Frederick.
Yeah, no, working on it. Yeah, you should be able now to share your screen.
Okay. I'll put this together while we were talking. Here we go. Tell me when you see the screen.
We do.
This is Russell and myself in Tenwek in February doing an esophagectomy. There's Keith. I haven't seen Keith today. Is Keith there?
No, he's not here. He is not able to be here on time.
Oh, there we are. It was a fun week. I really enjoyed that. So even the family had a really good time there. So, here we are. So this is just a short sort of step-by-step guide, but this is using the commercially available sponge, but as you see, you can also use the gauze as you did. So the first thing is to perform a gastroscopy and just to assess the defect. And as you can see, there's the true lumen to the left, and that defect is up on the right there. A plain nasogastric tube gets passed through the nose and pulled out through the mouth, and then that sponge or the gauze gets secured. And this is the technique used using the sponge. So a small piece just gets cut off and it's tailored to the size of the defect. And then, we wrap it around that tube and just securely fixate it with a silk suture. Oh, the end gets cut off as well, forgot to mention. So you can see there multiple sutures get passed just to secure it. So it only goes for another minute, I think. And in the end, you have a loop at the end that you can grasp with some biopsy forceps just to help direct the sponge.
So you're doing just what Corwinder described, anchoring the sponge directly to the tube so that it's your chance of
here we go. You got
the sponge is low.
And I use the biopsy forceps that don't have the teeth on it, because sometimes they can be hard to release. But this can be sort of the trickiest part of the procedure. So you need to guide this around the oropharynx and into the top of the esophagus, and then you lead with the sponge. So this is a video of actually showing the procedure. So as you can see, going posteriorly and leading with the sponge. And I guess once one of the keys is once the sponge is in the right position, you need to apply the suction before removing it because it keeps it in position. And then it's a matter of just releasing the forceps and coming back. But if you don't have the suction applied, as you withdraw the scope, you can actually dislodge the sponge. So this can take 5 minutes or it can take 15, 20 minutes to get it in the right position. And initially we'd be changing them twice weekly, just depending on what access the theatre was like. We always do them in theatre. And then it's just secured to the nose. So that's, and this is just a separate case. This is a slightly different technique. I call this a rendezvous procedure. So this is actually at endoscopy looking outside of an esophageal defect. And this is lung and a chest tube. And I've actually passed a jag wire through one of the tubes and then exchange it for a suture. But using this technique, we can actually just attach that external suture to the sponge and pull it down under vision. So this is actually looking at a dirty cavity through the esophageal defect. So you can see lung there. So at least we've got drain tubes externally there draining the sepsis. And I'll just jump to the next video. But this is just how easy it is to pass the sponge because we're pulling externally with this rendezvous procedure. So it just goes down the esophagus under vision. And when we get to the point of the defect, you just stop there. So now we know that sponge is just sitting nicely in that cavity. So that's all I wanted to share. So I'll just stop that now.
Also, I would like to sort of bring attention to a case series that was accepted for presentation at the last DDW coming out from Mayo. So although the DDW didn't happen, but it is actually as an abstract published in the journal Gastrointestinal Endoscopy, and it is called the endo-NIP procedure, NIP. It is negative intracavitary pressure. So what they described is that there's no need to put a sponge or a gauze. You can just take an anchoring catheter, like a pigtail catheter, put it into the cavity and apply suction. So I mean, the mechanism by which EndoVac works or any of such device works is the negative pressure being generated that causes macro deformation of the cavity. The micro deformation leads to some cytoskeletal changes that induces growth and healing, extracting the fluid that is collecting and sucking out the abscess material. So their claim is that why do we need a sponge if it is making life so difficult? Why not just go in and put in a catheter, like a anchoring catheter, and leave it in the cavity and apply suction? So that's called the endo-nip system or mechanism, which was just out as an abstract. Let's see what comes out of it in long-term or higher number of cases studies. Kind of just threw it in to bring attention to this approach also.
All right, Frederick, you have some people who wanted to ask some questions. Go ahead.
So Eric has raised the hand for a long time.
Thank you. I'm Eric from Sweden, pediatric surgeon. Thank you for sharing this fascinating case and discussion about this endovac. I guess it's initially developed within adult surgery. Do any one of you have experience for using this in infants? For example, newborns with repaired esophageal atresia with leakage? Any opinion about that or experience?
Yes, we
Cool.
have. Go ahead, Dr.
Go ahead,
White.
Agneta. No, you go ahead, please.
Yeah, I have some experience using the endosponge for infants with leaks post esophageal, congenital esophageal atresia fistula repairs. And also in toddlers who had caustic stricture injections, who either replace them like with a Gabriel or a reversed gastric tube replacement, and they have leaks, we manage them with this, or we use the coated biliary stents if you don't have that available.
Interesting.
And there's a paper out in 2018 in the Journal of Pediatric Gastroenterology Nutrition on the use of this technique in children in pediatric population.
And even in infants?
Yeah, so they describe this technique comparing it in a subset of them with stents. I mean, that's the only literature I found where this was used in infants and up to a particular age, I think about 10 years of age. From
Did they
infants,
decide what amount of negative pressure they use?
that I don't know. Yeah, yeah. But
Yeah,
it's in the Journal of Pediatric Gastroenterology and Nutrition in 2018 by Mansfredi.
Thank you very much. And may I also ask, it's been very good discussion about the esophageal repair here. I'm a bit curious about the tracheal repair. How large was the defect in trachea in this case presented? And was there any thought about tracheoscopy, or were there no signs of complication regarding the trachea?
Yeah, the tracheal defect, I mean, we purposefully erred towards the esophagus. As I alluded to earlier, in my estimation, it's neither the esophagus nor the trachea are easy to repair, but if you lose a lot of tissue from the trachea, you're really in a bad spot at that point. Trying to replace that becomes very difficult. You're going to get into some fancy techniques that will take a lot of time. So we purposely erred in that way. So the defect on the trachea was the smaller by far of the two. And I felt that we had very good apposition of tissue and we could directly suture that. I think if I were missing tissue in that case, I would probably do the same thing. We're talking about the posterior trachea, the membranous trachea, of course, so that putting a muscle flap on there and using that directly would probably suffice. If it were an anterior loss, then you might have to think about something with You might have to do a cartilage type transplant or something of that sort, or resecting trachea at that site and pulling it together can be done with some mediastinal release techniques, but it certainly becomes a greater risk throughout the case. And if things go bad, you can end up with a very poor outcome.
I have a question. What will happen to the latissimus dorsi muscle with all the food, everything going past the esophagus? For the trachea, you did a primary repair and then buffered that area with the muscle. For the esophagus, the latissimus dorsi now forms the wall of the esophagus. So it'll be curious to know, endoscopy done kind of 1 year or 2 years out, whether it got epithelialized with squamous epithelium, maybe with endoscopic ultrasound to see if the 5 layers came back, because myocytes are, like progenitor stimulating growth, acting like pluripotent cells, whether this would lead to regeneration of esophageal tissue versus the latissimus dorsi being a permanent wall and the muscle getting damaged with all the food and nutrients going past.
Yeah, that's a great question. And I think as we follow up this patient in the future, it'd be something to look at and consider what's going on. The last endoscopy that Mike showed, from an endoscopic point of view, it looked like we had virtual complete epithelialization. So that, yes, it did not look exactly like the esophagus. You can tell it's a different tissue, but there appeared to be epithelial growth over that entire area. So I think this would be something for us to look at down the road, and we'll see this patient and follow up for surveillance endoscopy. But a very excellent question to consider.
That was going to be my next question, Russ. How often do you plan on following them up, or what duration, and what's the likelihood of them coming back? Like, geographically, are they a long way away from you, or?
Yeah, Mike, let's have Mike comment on that from an endoscopic point of view. What do you think we should do as far as follow-up, Mike?
Yeah, I think because we've been scoping this child fairly frequently, and now that they're feeding and they're fine, I would say they were here 1 month ago. So it would be like see them at 3 months and then at 6 months. And then if they're fine, we can let them go home and come back after a year. Because the main goal is to make sure that there's no more leaks and no more unresolved chest issues from a pulmonary standpoint, which from the last visit, they were gaining weight. They've actually gained very good weight, and now the child is back to normal activities. So we'll plan for follow-up. They're from quite a distance, but they can make it for repeat clinic visits.
And if they develop a stricture, will you do a balloon dilatation, or what would your management be of that?
So if they did get a stricture, I think I would opt to do a balloon dilation, as it's more controlled. We can actually start from a smaller balloon and work our way upwards, as opposed to doing the Bugin edge type dilators. And plus, we know we did a repair, and there's a suture line somewhere in there. So routinely in the past, for this type of post-operative strictures, we've been doing balloon dilations on their follow-ups. And then Savary, if they come back much later on. Maybe Kulwinder could comment also on that dilation from his experience.
Yeah, I mean, dilation definitely, I hope based on what was done, the kid does not develop any stricture. And the way it looked on the last endoscopy you did, the healing process is going pretty well. A small patch of that muscle is seen. And I don't think that's going to contribute much towards a stricture formation. The only thing is that when the kid is going to be growing in height and the esophagus is going to lengthen as the kid grows in height, what will happen to that segment of the esophagus, whether it'll be a problem. And that's why it'll be very interesting to see what happens in long-term follow-up. Otherwise, dilatation is going to be any standard technique. I would prefer a balloon, as you pointed out, because of a good control we have on the size we can use and radial expansion compared to radial versus longitudinal forces with a bougie. So if at all it comes to dilation, I agree, I'll go with the balloon and be very gradual with it, considering the fact that we don't want to rip that area open and cause another problem.
Frederick, did you mention that someone else had a hand raised and wanted to speak? Please
Sure.
go
Yeah, we
ahead
have
if that's true.
Hiroshi. I think you have a comment.
Oh, yeah, thanks. It was a fascinating case. Thank you very much. You know, being an adult gastroenterologist, it's pretty rare to see, you know, coins lodged in the esophagus, mainly because once it passes the UES, it should come down other than for, let's say, a Schatzki's, which would then lodge, you know, in the distal esophagus. What is interesting, though, is that you have a coin here lodged in probably the where the squamous, the skeletal and the smooth muscle interdigitate, and that, it turns out, is a point in the esophagus where the pressure wave is the weakest. And so that probably combined may do this. That said, you were, Russ, you were making the point about, you know, batteries. And one of the issues that may come up is that coins that are of composite nature, for example, in America, we have pennies that, or at least more recently in the past 10, 15 years, have been a composite of copper and alloy. And that, of course, creates a battery situation where currents are made. So it'd be interesting whether this coin that you describe is a composite rather than, say, pure copper or not. So that may be a question. And then secondly, not being an adult gastroenterologist, are you seeing more of these kind of impactions at this, from an adult point of view, relatively odd mid-esophagus or higher esophagus?
Agneta, why don't you answer that question? It does strike me that we see these frequently in kids, and I think we don't classically, of course, teach that there's a narrowing of the esophagus at the level of the tracheal carina, but we frequently see them at this site, and they're frequently coins. And I think the bulk of the trachea there is probably what's causing that. Agneta, do you have thoughts about that? You've seen a lot of these at Tenwick yourself.
Yes, I think because of the size of the anatomy in a pediatric population, at the carina we have the left main stem taking off. That's where the foreign bodies tend to lodge, and then cause the erosion and fistulization, especially if they're undiagnosed. So that would be the typical location.
Yeah, in adults, we would think about, of course, malignancy first than anything. So at that level.
There was a question on the use of fibrin glue. Maybe Dr. Agneta can comment on that because she's had some experience with that. The question was fibrin glue following repair of the esophageal defect or prior to, as primary repair for esophageal defect.
Yeah, so I think definitely there's consideration for use of endoscopic or bronchoscopic fibrin glue application. I think the factors to take into consideration would be the size of the fistula. So the indication for this modality would be a small sized fistula. And for particularly the foreign body impaction with subsequent fistulization, the advantage is that if they present over a period of time, the fistula tract has epithelialized and matured, if you will. So the important thing to consider is that you have to irritate the mucosa to allow the fibrin glue to set and seal the fistula defect. And for that, you can either use endobrush to irritate the mucosa, or you can use like a Bagby cautery with special consideration to the site not to cause perforation into adjacent structures. And you can actually repeat the endoscopic or bronchoscopic application up to 3 to 4 times before you deem there is failure, as long as the child is clinically stable and nutritionally optimal, before you can proceed to an open surgical repair of the fistula.
Yeah, and I see there's also a question about what is the end point for stopping the VAC treatment and going in for surgery. I would, as Agneta just mentioned, if the patient is looking clinically well and not showing signs of overt sepsis, I would persist with endovac therapy because I know that going back in, the chance that I'm going to end up doing a diversionary procedure with a spit fistula in the neck and eventually leading probably to an esophagectomy is very high. Going back in a second time into that site and trying to repair a patch, a muscle flap, is going to be bound to cause some more troubles. It's going to be a hostile environment 3 or 4 weeks into the situation. So I think I would really persist. If they're looking ill, then of course your hand is forced. And I think that at that point, you're going to have to divert to a cervical spit fistula and completely exclude the GI tract. And you're probably then looking at an esophagectomy down the road, which I would try my best to avoid in a child like this if I could. Frederick?
Sorry.
Yep.
Just planning for a future esophagectomy. What part of the stomach did you use for your gastric tube?
We would use what most people standardly use.
Oh, no, sorry, I meant in this case, when you've already placed the gastrostomy tube, which part of the stomach have you already used for that?
Well, I don't find, I've done quite a few esophagectomies on patients who've had a gastric tube before, and I haven't found that to be limiting significantly. Just taking down the gastrostomy, freshening the edges and closing that defect it has worked quite well. Obviously, it wouldn't be my first choice to have a stomach used with a gastric tube. If there's a reason to put a tube, I would definitely prefer a jejunal tube so that the stomach is left virgin. But if one is in place, I don't think it causes a major problem, and you can just take it down and close it and continue to use the conduit as usual.
But when you placed it originally, you didn't aim for like the lesser curved side of the stomach, just in case you needed that greater curved side for future?
We did when we in the stomach than we normally would on the anterior surface of the stomach, thinking that if we were going to need that proximal stomach up in the neck, of course, that's the most ischemic part when you do a gastric pull through. So we wanted to avoid a gastrostomy tube there and put it in the more distal stomach.
Yeah.
All right, Frederick, you're in charge, I think. If there are more questions, happy, but the timing looks to be up.
Yeah, we've been to all questions and comments. So unless you have a last point, Wassel, I will let you go to the conclusion and close the session.
All right. Well, thank you all for participating in this. We've enjoyed doing this. As I mentioned, our kind of standard bread and butter work at Tenwick is esophageal cancer, which we see every single day. But we thought this was an interesting case. This was the first time that we've used negative pressure endovac therapy, and we were pleased with the outcome. I hope this encourages others to consider that in these cases. I know I will be considering this significantly particularly in our setting. The most common would be if we have a leak following esophagectomy. To use this, it makes good sense to me. We use them all the time in other parts of the body. The negative pressure, as Kulwinder mentioned, provides significant stimulus for angiogenesis and evacuates infected material and purulent drainage. So it really is helpful. I'm grateful to the person who took the technique from the usual places, lower extremities, buttocks region for wounds, and had the wisdom to say we could use this in the esophagus.
That was a very good thought, and we will continue to use this. I think the take-home points, which we've already mentioned, apply. Multidisciplinary team is key to achieving good outcome in these patients. Watching the patients carefully and being alert for subtle changes that may indicate a problem, and addressing those early. Not walking by the patient's bed, seeing they have a slight fever, elevated white count, and saying, well, it's probably atelectasis, let's hope it gets better. That's probably the wrong answer. It's not even probably the wrong answer, it is the wrong answer. You should probably consider that you have a leak until you can prove otherwise. So thank you all for attending. We're very happy, and Matt has been one that's come to visit us there at Tenwick. I would welcome any of you others who want to come and do a game drive. You're welcome to do that. It looks like Hiroshi is already on his game drive. He's got rhinoceroses sitting behind him as we speak. He's a brave man because they are mean animals. But our hospital is located about 35 miles from the Masai Mara Game Park. So it's a place you can come and see some.
So he promises elephants.
There are always elephants in that park. You will always find them. I do promise that. I won't promise you a
There are
leopard.
always elephants.
You say 35 miles, but you have to say a 5-hour drive.
You had a slow driver. No, I can do that in 2 hours over to the Masai Mara. If you have the right vehicle, it's a rough road, but it's fabulous scenery to see over there. So you're all welcome in the spirit of Oeso and cooperating and seeing other centers. You're all welcome to come and spend a few days with us, and then spend a few more days in the game park enjoying yourselves in Africa. So thanks very much. That's all from us at Tenwick, and we look forward to the next one.
Yes, and the next one will be held, may I say that it will be organized by Professor Yusheng Mao, who is in the audience today, together with Professor Jie Ho in Beijing. It will be on October the 29th, and I think we should be prepared to a very fascinating discussion on esophageal cancer involving teams from China, many centers from China, centers from Europe, from America, and from Africa, of course, because Professor Russell White and his team will be also participating in the discussion, which will be organized in Beijing at the end of October. And thank you for the contribution of Matthew Reed, for Gulwinder Dua, from Dr. Omling from Sweden, and I saw our old friend Larry Johnson also in the audience, and I say hello to him. Thank you so much for participating today in this fascinating discussion that we had on this specific case of esophageal trauma. Thank you for being here.
Thank you all. The recording of this session will be made available on the YouTube channel.
I will also invite all of you to participate or discuss.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.